Welcome to the Hemophilia Guidelines from the WFH. We're using this to help you learn about haemophilia and managing patients with haemophilia. These are the guidelines for the management of haemophilia, the third edition, that were published in 2020 in the Journal of Hemophilia. In this video, I'm going to focus on Chapter 2, the comprehensive care of haemophilia. I'm Kate Khair. I'm the Director of Research at HemNet. I also work in the Centre for Outcomes and Experience Research in Children's Health, Illness and Disability at Great Ormond Street Hospital for Children, and am a haemophilia nurse. These are my disclosures. I'm very happy to be presenting Chapter 2, the comprehensive care of haemophilia, on behalf of my co-authors, who are Elena Santagostino, Alison Dougal, Matthew Jackson, myself, Richa Mohan, Kim Chu, Augustus Nedzinskas, Margaret Ozello, Marika Vandenberg, Glenn Pierce, and Alok Srivastava. What I think is really important here is that we have the views of people with haemophilia as well as healthcare professionals. Before I start talking about the Chapter 2 and the comprehensive care of haemophilia, just a brief introduction to haemophilia itself. So haemophilia is a rare X-linked congenital bleeding disorder. So people are born with it. There is acquired haemophilia, but we're not discussing that in these guidelines. Hemophilia A is characterised by a deficiency of coagulation factor 8 and is sometimes called classical haemophilia. And hemophilia B is a deficiency of coagulation factor 9 and is also sometimes called Christmas disease. Somewhere between 30 and 50% of all new cases of haemophilia result due to a spontaneous genetic mutation or variant where the gene that makes factor 8 or factor 9 goes wrong. And about half of people that we see with newly diagnosed severe haemophilia have no prior history of haemophilia. And of course, accurate diagnosis is essential because both haemophilia A and B present in the same way. So we need to know whether you have haemophilia A or haemophilia B so that we can give you the appropriate management. Haemophilia A is much more common than haemophilia B, with somewhere between 80 and 85% of all patients with haemophilia having haemophilia A. Haemophilia B is much rarer, but that doesn't mean that you can't still have it. There's lots of people with haemophilia B still. The prevalence in per 100,000 males is therefore much commoner in haemophilia A at 17.1 and much less in haemophilia B at 3.8. And the prevalence at birth is higher per 100,000 males than it is in the population. And sadly, that's because some people with haemophilia die and some die before they get a diagnosis. So based on the prevalence of all cases of haemophilia A and haemophilia B in 2020, we predict that there should be about 784,000 men with haemophilia in the world. The majority of these remain undiagnosed. And without a diagnosis, you don't get access to treatment. The clinical diagnosis of haemophilia is mainly easy bruising, which, as you can see in the top picture here, is very easy to see in children who have fair skin. These bruises occur equally in children with dark skin. You can't see them, but you can feel them. They also have spontaneous bleeding, which could be from the mouth, the nose, and excessive bleeding if we do things to them as healthcare professionals. They also present with joint bleeds at a very young age, usually at around about 10 months old when they're starting to be mobile. And these are really a key indicator of severe haemophilia. The other indicators of severe haemophilia are soft tissue and intramuscular bleeding from an early age, bleeding associated with medical procedures, mucocutaneous bleeding, so bleeding from the nose or the mouth, and intracranial bleeding, so bleeding into the brain. The severity of haemophilia correlates with the degree of clotting factor deficiency that you have. So not only is it important that we work out in our laboratories whether you have haemophilia A or B, but what the level of factor 8 or factor 9 that you have is. People with mild haemophilia have levels of between 5 and 40 international units per deciliter. Sometimes that's reported as 5 to 40%. And they may not have bleeding problems until they have surgery or trauma. And so they might present later in life. People with moderate haemophilia have levels of 1 to 5 international units per deciliter of factor 8 or factor 9. And they may have occasional spontaneous bleeding and bleeding following trauma or surgery. And again, they sometimes don't present until a little bit later in life, but not as late as those with mild haemophilia. And people with severe haemophilia have an unmeasurable almost level of factor VIII or factor IX with a level of less than 1 international unit per decilitre. And they're the ones who present early in childhood, so usually by the time they're 8 or 10 months old and they're starting to be mobile, and they experience bleeding into joints, muscles and organs. Of course, all of these people with haemophilia can bleed following surgery. And so if you're somewhere in the world where you practice religious circumcision, it's possible that you'll be diagnosed early, even if you have mild or moderate haemophilia. We know that for people with haemophilia, the best way to look after them is to offer comprehensive care. And that is a lot of healthcare professionals who work with the person with haemophilia and his family in providing the best care for him. And that's not just physical care, but also psychological care through counselling, social workers, as well as nurses and doctors looking after you in the acute bleeding situation and teaching you how to look after yourself. And the WFH really recommends that this coordinated delivery of comprehensive care by the multidisciplinary team for people with haemophilia, because we know that it provides the best outcomes for people. So in comprehensive care, we recommend that people with haemophilia have availability of and access to appropriate emergency care at all times. And that might be coordinated by the haemophilia centre, but delivered locally at a hospital closer to where the person lives. The comprehensive care should have a coagulation laboratory, which is able to perform clotting factor assays and inhibitor testing in a timely manner. They should also have appropriate clotting factor concentrates, which may be plasma derived or recombinant, as well as other hemostatic agents such as desmopressin or emicizumab and antifibrinolytics to enable prompt and appropriate treatment of people when they bleed. We also recommend that the blood components, such as fresh frozen plasma and cryoprecipitate, should be adequately screened, tested and virus inactivated for use if clotting factor concentrates are not available. As well as treating people with bleeding with clotting factor concentrates, we also recognise the role of the physiotherapist in casting or splinting and immobilising painful joints and providing mobility and support aids if needed. And other specialists will be there to address specific medical and health-related issues which you may encounter. It's also really important to remember that antifibrinolytic drugs, and we'll talk about those a little bit later, are a really effective treatment for mucosal bleeding and invasive dental procedures. And these can be kept at home, and so patients can then use them at the start of bleeding, which helps, we know, with clot formation and treating of bleeds quickly. We also recommend that people with haemophilia have a multidisciplinary checkup, including a haematologist, physiotherapist doing a musculoskeletal assessment and quality of life assessments at least every year. And for children who are growing and developing, that should be more often, ideally every 6 months. And that is so that we can make sure that there are no problems developing that we're not picking up if we don't see you. And so it's important that you come to those review appointments. It may be that your smaller centre or your local hospital or your family physician can provide the primary care and management of some of the complications that you may have with your haemophilia. And that's really important that that is done alongside the haemophilia comprehensive care team. We recognise that for those of you that live a long way from your haemophilia centre, that's a good way of maintaining good health for you and good follow-up for us. In recommendation 2.2.5, we move away from treating people with haemophilia to recording the treatment that we have given and the outcomes that we're getting from that treatment. And we see that that's really important to collect that data in a systematic way in patient registries where possible at a national level to inform the allocation of resources, but also to improve the care that we deliver to you and promote collaboration between our centres in sharing data and conducting future research. Another key part of comprehensive care is about us helping you to look after yourselves. It's really important that we educate and support you so that you can do that and manage yourselves and your haemophilia at your home and not having to come to hospital all the time. This is a really important role of the comprehensive care team. So we recommend that adequate education is given to people with haemophilia and their family members and any other caregivers that they may have to enable you to manage your haemophilia yourself with enough understanding about your haemophilia to prevent bleeds, to prevent other complications, to plan your life, but also to live your life well. We say that for people with haemophilia and their families, health promotion, education and recreational activities in collaboration with patient organisations should be delivered. This enables you opportunities to discover new interests, new capabilities, and to build a support network with diverse members of your haemophilia community. We recognise now, more so than ever, that remaining fit and physically active is really good for you if you have haemophilia. It's good for your muscle strength and it's good for your joint health. And so we recommend that we promote regular physical activity and fitness with special attention on bone health. And that can be just walking. That is really good for your bone health. Strengthening your muscles, coordinating your body with physical functioning, maintaining a healthy body weight so that the weight going through your joints isn't too great. And that also promotes a positive self-esteem. And it also means that you can do the same things as your peers. We recommend non-contact sport. In some countries, it's easy to participate in sport where you have access to treatment, but for those that don't have regular access to treatment, avoiding high contact and collision sports and high velocity activities is the best thing, because that reduces the amount of time that you're likely to have injury. But of course, if you're able to access prophylaxis, you should be able to have that non-contact sport with prophylactic cover. But remember that each and every one of us is an individual. And so the choice of sports that we participate in should be our individual's choice. And we should discuss that with our haemophilia team and with our physiotherapist, thinking about our own interests, our local customs, and the available resources that we have. If you talk to your physiotherapist, it's very important that they look at you as an individual and think about your musculoskeletal health before you decide which physical activities you're going to undertake. And when we're talking about physical activity, we're not just talking about sport, we're talking about being able to take the dog for a walk or take your children to and from school. So think about with your physio or your haemophilia team as an individual what you can and can't do safely. And also then think about any protective equipment that you might need, such as helmets, or if you're going to play contact sport, thinking about having a custom-made dental mouthguard to prevent trauma to your teeth and your oral soft tissues. Haemophilia care is not all about factor replacement therapy. There's lots of things that we can do that will help you when you've had a bleed to recover and help you to regain your previous level of fitness. And one of the most important things for you to learn about is PRICE, which is protection, rest, ice, compression, and elevation. And so if you do get an injury, think about protecting the injury that you've got. So don't continue to walk if you have a knee bleed. Rest. If you can access ice, then put ice onto your joint in a safe way. Don't put it directly onto the skin, but use a towel between the skin and the ice. Think about compression. So does a bandage, a support bandage help you? And sit with your leg up. When you're recovering from that joint or muscle bleed, we need a gradual initiation of physical activities under the supervision of a physio, if you have one, or your haemophilia team. So don't re-engage in activity if your bleed hasn't completely resolved, because you will re-bleed and that will cause you further problems. And we know that for children with haemophilia recovering from a joint or muscle bleed, the physiotherapist and the family caregiver should remain in close contact to discuss the appropriate sports and activities for the child as they move forward. And that can be over the telephone or by video or Skype. It doesn't have to be a face-to-face meeting. So here we come back to the use of antifibrinolytic drugs, and in recommendation 2.4.4, we talk about the use of tranexamic acid or epsilon aminocaproic acid, either alone for simple mouth bleeds, perhaps for people who don't have such good access to clotting factor concentrates, or in conjunction with those clotting factor concentrates. And they're particularly good at controlling mucosal bleeding and if you are going to have invasive dental procedures, when you could start this treatment at home the night before and hopefully not have any bleeding at all. The whole aim of haemophilia care is to treat bleeds as quickly as possible, because we know that if we're able to do that, we reduce the long-term implications of joint damage. And so the easiest way to do that is to be able to do treatment at home. And obviously that is only where people are able to have access to clotting factor concentrates and to be able to keep them at home. It gives you then the opportunity to learn how to self-infuse and how to treat yourself quickly when you have a bleed. And that means that you will get better more quickly, you'll have less pain and less long-term disability. But this also means that you need to have some concrete knowledge about how you bleed and when to treat and how much treatment to give. And this is where the comprehensive care team is really important in providing education and support to you as patients. You should also, as a patient or a caregiver, understand the differences and the benefits of risk associated with particular treatments, and that's whether you're getting a plasma-derived or a recombinant product. And again, that's about talking to your haemophilia care team. But most importantly, you need to know when you have a bleed and whether that's a joint or a muscle bleed, and how quickly you can and should treat it to benefit from the both long and short-term impacts of that treatment. So in section 2.5, we have a few recommendations about self-management, and they are key if you're able to do this. So parents of children and then patients themselves with haemophilia should be taught how to manage your care at home and should learn how to be able to self-infuse. And we as healthcare providers should monitor your venous access skills over your lifetime. Veins get more difficult or easier to use depending on how often they're used and how fit you are. We know that once you have that treatment, you should keep a detailed record of that treatment, the reason why you were treated, the batch number and the number of units. And that's for you as a person to realise how you are responding to treatment, but also for us as healthcare professionals to provide all of that data to show how we manage haemophilia care. And for some children in some parts of the world where they start prophylaxis early, it may mean that a central venous access device is necessary. And that should be discussed again between the haemophilia team and the parents. So I'm just going to highlight some of the situations that you might see in haemophilia with this case study of Simon, who has moderate haemophilia and was only treated when he had bleeds. He lived a very long way away from the haemophilia centre, and as a small child didn't like going there because he realised that going to the hospital meant he was going to get an injection. However, as he got a bit older, he learnt that his bleeds got better more quickly when he recognised them early, told his mum or dad about them, and then got treatment. So often children, if they don't like coming to hospital, try hard not to tell you that there's a problem. So once he realised that he could get better more quickly when he got his earlier treatment, he realised that he got some bleeds from doing some activities, and he didn't really want to stop doing those. And so he talked to the haemophilia nurse and physiotherapist at his haemophilia centre and worked out a safe way to carry on doing those activities and how to treat himself at home, not just with factor, but also with things like price, so the rice, elevation and compression. And he worked out that living with haemophilia wasn't so bad after all. He learnt how to manage his haemophilia and to be in control with it. One of the things that we know and are increasingly interested and working on, because we're probably not very good at managing it, is how painful it is to have haemophilia. And so there is a large section of the new guidelines in the comprehensive care chapter about pain management. And we realise that pain can be acute when you get a new bleed and chronic. And we want to use appropriate pain assessment tools when you say that you have pain to determine the cause of your pain, because it might not always be an acute bleed, to guide the appropriate management, which might be physiotherapy and rehabilitation. We appreciate that if you're having repeated venous access to give your clotting factor concentrates, that is actually painful, it's uncomfortable and causes anxiety, particularly in small children. And so we recommend that local anaesthetic sprays or creams are used where available to limit the pain at the access site for your venous access. We know that when you have a bleed, be it a joint or a muscle bleed, that it is very painful. We recommend that you have immediate administration of clotting factor concentrates to stop the bleeding, and that will reduce the pain overall because it reduces the size of your bleed. But also carrying on with the price, so the rest and the ice and the compression and splinting to minimise the pain if appropriate. And we also realise that you can have dental pain just like anybody else can have acute dental pain, and that should be treated appropriately with appropriate pain relief and referral to a dental care professional for assessment. Patients with haemophilia who have surgery have postoperative pain just like everybody else, and we advise here that there is appropriate management of the pain coordinated with the anaesthetic or pain specialist in the hospitals. It may be that some people with haemophilia are having large doses of painkillers every day of their lives to manage their normal pain, and then on top of that they get acute pain following surgery, and so we need specialist intervention to help manage that pain. We recommend here that patients are treated the same as people without haemophilia for analgesia, using all of the steroids, the opioids, and things, simple analgesia like paracetamol, as the pain decreases. The only slight problem is that non-steroidal anti-inflammatory drugs should not be used in people with haemophilia because that makes your bleeding worse. And so, with the exception of a few of the COX-2 inhibitors, non-steroidal anti-inflammatory drugs should not be used. And the intramuscular route for administration of analgesia is not advised because that can cause muscle bleeding. When we think about haemophilia, we think about people who have arthritic joints, which we call hemophilic arthropathy, and that's obviously very painful. And so alongside analgesia and pain management, we also now recommend functional training and adaptations, so thinking about whether there is something that we can do to help you walk more easily. So it may be that you have one leg that is shorter than the other, and so an insert into your shoe as a functional change to the way that you walk can reduce your pain. Again, if you need to have pain management, that can be through other things than just analgesia, so things like meditation, distraction, mindfulness, and music therapy, all of which are well known to work. But we do realise that having haemophilia is painful and that we don't treat your pain well, but we should do better. And so in recommendation 2.6.8, we talk about how we should treat your pain with paracetamol, if it's a simple pain, and then moving up through all of the drugs that we have available to treat people with pain through the COX-2 inhibitors, tramadol and morphine, but avoiding non-steroidals where possible. We need to take particular care with codeine because in children under 12 it is contraindicated because it converts to morphine as it's excreted and can be very difficult to manage in children, and so we try not to use codeine in children under 12. We know that prolonged use of some of these medicines has in the past led to people becoming dependent or addicted to the drugs, as well as causing some organ damage, which is why we carefully monitor the amount of painkillers that you're using. That doesn't mean we're wanting you to suffer pain. It means that we're wanting to make sure that we're treating pain safely. And because of that, we think that people with persistent pain should be referred to pain specialists who are much better at managing chronic pain than we are as haemophilia clinicians. And if you have chronic pain that is associated with disability, so your hemophilic arthropathy is the cause of your pain, then we recommend referral to an orthopaedic specialist for consideration of orthopaedic surgery, which is dealt with in other chapters. So one of the many areas where we see pain is in dental care, and there's a misconception that having haemophilia makes you more likely to bleed from your gums and your teeth than if you don't have haemophilia. And actually the reason that you bleed from your gums and teeth is because you've got poor oral hygiene, and that is the cause of the bleeding, not your haemophilia. So we really do recommend that people with haemophilia have the best dental care and management possible, that children with haemophilia should be referred to a designated dental care centre as soon as their teeth start erupting, and that they should have very good oral hygiene provided by their parents initially and then by themselves as they grow and become able to look after their own teeth. For adults with haemophilia, we again recommend that patients have access to appropriate dental services for procedures, and that's because many local dentists would not want to take out teeth in people who have haemophilia, and so it's important that they have extra special dental assessment and care. So to prevent all of that bleeding and periodontal disease, dental caries and dental extractions, we really do recommend that people with haemophilia have the best preventative dental and oral care as part of their comprehensive care for their haemophilia. And that involves, in recommendation 2.7.5, really good education on the importance of good oral hygiene to prevent those problems and complications from occurring. And that is simple toothbrushing using a soft or medium textured toothbrush, fluoride in the toothpaste to remove the plaque deposits. Toothpaste should not be rinsed away, but keep it in your mouth. You spit it, don't spit. You can spit, but don't rinse it away because actually the fluoride is really good for your teeth. Dental floss or interdental brushes should be used as well, just like you or I would do. And we need, though, to think about people who have got arthritic damage of their elbows or their shoulders, where their mobility may be restricted, and then perhaps they need a modification of their toothbrushes, so they just need a longer handle to their toothbrush, or maybe an electric toothbrush and flossing aids. So people with haemophilia do have dental extractions and other invasive procedures within their oral cavity, such as in their mouth, so they might need a gum biopsy or a dental implant. And there's no reason why they shouldn't have that. Just because they have haemophilia doesn't mean they can't have good dental care and surgery if necessary. So we recommend that patients use, as we said earlier, either tranexamic acid or aminocaproic acid as an adjunctive treatment to the management of dental interventions, and that should be planned very carefully with the dentist and the haemophilia team. It may be that the care given could be adequately treated with just tranexamic acid and or aminocaproic acid, and no need for factor replacement therapy. We need to be aware that patients should have a soft diet and gentle brushing around the wound site, even when they've had extractions, for 3 to 5 days to avoid disturbing the clot and making the socket rebleed. And we know that that helps them with healing. So we've talked a lot about children and adults with haemophilia being looked after in comprehensive care centres, and we have two issues that we sometimes overlook. One is that children are often looked after in paediatric or children's hospitals, and that they need to move at some point to an adult hospital, but also that children that are in a combined centre need to move from paediatric to adult care. And we need to think carefully about how we do that so that we don't lose those young men when they move on to adult care, because that's the time that we want them to be thinking about becoming self-reliant, moving away from home, and assuming full responsibility for their self-care. So transition is a process, and it should start from boys being as young as 6 or 7 when we're starting to teach them about haemophilia and about their self-care, through to the age at which they can take full responsibility in adult care, which might be 16 or 18 or beyond. So we need to do that in a safe and strategized way. So we need a transition plan that involves not only the young person with haemophilia, but also his siblings and his parents. And we need to remember that some of those siblings might be girls who carry haemophilia or have mild haemophilia themselves, and so they might also have bleeding problems. We need to think about the time that is the right time for the individual patient. So it should be a developmental stage, not an age stage. We should do this in an individualized way, and ensure that there's added support when they're switching to that self-treatment and or moving away from home, so that they don't feel unsupported and lost. So here's a case of a good transition from James, who was 2 when he was diagnosed with severe haemophilia. There was no previous family history, and his parents learnt to do his care from a very young age when he started with prophylaxis. When he was 10, James went to a summer camp and met other boys with haemophilia. And for the first time, he saw them doing their own injections and was keen to learn how to self-infuse to become more independent. And by the time James was 16, he was able to manage his own care. He understood the need for treatment. He understood why he should exercise to look after his joints and why he needed to come back to the haemophilia centre for follow-up. So in paediatrics, all of the education that we do with parents right at the beginning, at the time of diagnosis. It's really important that we revisit that education with the young people themselves so that they understand why we're doing what we're doing now, which is probably very different from how it was 16 years ago when they were diagnosed. And when James moved on to the adult hospital, He became a buddy for younger boys with haemophilia, and he's a good role model for other youngsters with haemophilia, which is what we want to see, that network of peer support. So in section 2.8, we have some recommendations about transition from paediatric to adult care. And that is the most important, is that children and adolescents should be supported with their ongoing education and skills development. So once they get to adult care, there's no supposition that they know everything they need to know about haemophilia, and that they continue to be educated by the adult team to understand the knowledge of their self-management and their condition as they develop into adulthood. And ideally, if that's possible, the comprehensive care team should morph slightly at that stage. So the first or maybe subsequent visit should be performed by both the paediatric and adult haemophilia comprehensive care teams if possible. Where adolescents with haemophilia are on prophylaxis, we recommend that individual education and training from the nurse coordinator is given to ensure adequate knowledge of haemophilia and to support prophylaxis at this difficult time of adolescence, when perhaps adherence and self-care management may wobble slightly. And there we need to have a real knowledge and understanding of why adherence or doing your treatment at the right time is a good thing, as well as the factors and the risks that can lead to changes in bleeding rates. So we know that this is a time when young men push boundaries to see what they can and can't do. And they can do that as long as we've got a good relationship with them, and they can do that safely. And then we also recommend that between the ages of 12 and 18, maybe a little bit younger, like James did, that there are some age-specific haemophilia camps to really foster that peer support between young men with haemophilia. Sometimes these young men don't know anybody else. This is the first time that they meet somebody else. And that's a really important part of that growing and understanding about living their lives. So in conclusion, the multidisciplinary comprehensive care team promotes best healthcare and outcomes for people with haemophilia, and that includes education and support of the affected individual and his family and caregivers. Their engagement with the comprehensive care team is really important to ensure individualised, age-appropriate care for all affected people. And self-management skills should be taught for all people with haemophilia to ensure the best outcomes possible for them wherever they are in the world, and a life well lived. I would like to thank the Haemophilia Alliance for support in developing this presentation, and thank you for listening.